Hello. Good afternoon, everybody. It's a pleasure to receive you here, and thank you so much for attending this section. My name is Pedro Rosaneto, and today we will start a session called Read with the Experts. So the first expert to talk about PET and in the context of dementia is Professor Chris Rowe. He is going to talk about how to read PET FDG. The second person to present is myself. I'm Pedro Rosaneto, and I'm talking about amyloid, how to read amyloid PET. And the third speaker is Professor Kirk Fry, and he is going to talk about the cases with myself and Professor Rowe as well. So I'd like to remind all of you that we have to turn off your cell phones. For the ones collecting CMEs, you have to scan the QR code in the end of the session. And if you want to know about the latest development here in this meeting, please consult your app. Please, Chris.
Okay, so FDG PET, an oldie but a goodie, and I'm going to just go through how I read them. So it's not that FDG PET's new, it's been around, as we heard in previous talks, from at least the mid-80s. Here's some images from 85 showing progression in a patient in 87. We've found here in Australia that FDG PET has actually recently rapidly increased in popularity. And my PET centre does about 1,000 clinical FDG PET scans per year now for dementia assessment. There's a few reasons for this, which I'm not sure if I've got on the next slide. No. A few reasons. All the talk about amyloid PET certainly has stimulated interest in molecular imaging amongst memory disorders specialists once again. The automated quantitative programs are now give more reliable assessment, as I'll show you, and even the referring doctors, if you send them out pictures of the automated quantitation surface rendered maps, can see what's going on and they can read them themselves, which is very good for referring doctors. But a bit of revision, why do we need more than a CT scan in dementia assessment? Because the CT can detect the so-called treatable causes of apparent dementia, such as subdural hematoma, normal pressure hydrocephalus, frontal tumours, not terribly treatable, and strokes. So for typical cases of Alzheimer's disease, you can make a reasonable case that a CT scan, being very cost-effective, is good enough. However, for earlier diagnosis, for atypical presentations, or for diagnosis of non-Alzheimer's dementia, you need more advanced imaging. Now, the first step is MRI, but we're not going to talk about that today. But MRI has limited applicability in dementia. It's good for vascular disease, giving you an idea of the potential contribution to the cognitive problems that's being made by brain ischemia in terms of strokes. It does show hippocampal atrophy, but that's not terribly specific. You get it in all forms of dementia to some degree. So we come back to molecular imaging for specificity and sensitivity. Why? Because clinical diagnosis of Alzheimer's disease without support from biomarkers is not that sensitive nor specific when compared to post-mortem diagnosis. So really the specificity is only 70%. So 20 to 30% of the people in the community who've been told they have Alzheimer's disease don't actually have it. You also require the presence of dementia to meet the typical clinical criteria for Alzheimer's disease. But we now know from imaging and other studies that the development of Alzheimer's disease is a process that takes 30 years. People are symptomatic in the mild cognitive impairment phase for 3 to 5 years before they hit dementia. And over this time, you officially can't make a clinical diagnosis of Alzheimer's disease. fact, even if you tried during the mild cognitive impairment phase, you'd get it wrong in 50% of cases if you just equated mild cognitive impairment with early Alzheimer's disease. Turns out that only 50% of people given a label of mild cognitive impairment progress to Alzheimer's-related dementia. 15 to 20% get other dementias, and about a third of them don't actually develop dementia with prolonged follow-up. The only way to diagnose what's going on in somebody with mild cognitive impairment is with biomarkers. And the research criteria have evolved. I went into this in more detail in one of my earlier talks, but way back in 2007 this was appreciated, and the role of biomarkers was being inserted, and the need for dementia was being taken out of the diagnostic criteria for Alzheimer's disease, at least in the research context, but what's in the research area eventually gets into clinical practice. So if you've got a history of cognitive decline, you've got clear abnormalities on testing, and the suspected disease is supported by a biomarker, such as FDG PET, amyloid PET, CSF studies, you can make a diagnosis of Alzheimer's disease. So, FDG PET. This is a classic slide from Eric Ryman, published in New England Journal of Medicine back in 1996, showing very nicely the parts of the brain that are affected in Alzheimer's disease. So I'll get my... Oop, and he hit the wrong button. Okay. So on the lateral view of the brain, there's the posterior parietal cortex. There's the lateral temporal cortex. On the medial views of the brain, there's what's called the posterior cingulate. The cingulate gyrus is a gyrus that runs over the top of the corpus callosum here. You have the anterior cingulate, mid-cingulate, posterior cingulate. The anterior cingulate crops up in a lot of psychiatric literature. It seems to have a role in anxiety and mood disorders. The posterior cingulate is a very important integration centre for memory and part of the limbic memory circuit. And then the precuneus, which is basically the posterior medial part of the parietal cortex. So here you've got the sulcus between the occipital lobe, referred to as the cuneus, and the parietal lobe. So this section's called the precuneus because it's just in front of the cuneus. So these are the areas in which you see hypometabolism in Alzheimer's disease. This one doesn't show much frontal reduction, probably because this was created, I suspect, from younger Alzheimer's patients, but certainly in older Alzheimer's patients, you also see a lot of frontal reduction. Now, how to read them? Step one, make sure you've got the brain orientated correctly. And that is the anterior commissure, posterior commissure plane. This is an old plane derived by neurosurgeons back in the days of air encephalography, and they used it to orientate the brain when trying to do stereotactic procedures. So based around this plane is actually a coordinate system that neurosurgeons are very familiar with, and it's still used today. It is quite simple. It corresponds to the base of the frontal lobe to the base of the occipital lobe. So basically you make the brain flat. When you do that, you end up with the primary sensory motor cortex in the middle of your axial views. And that's very important because the primary sensory motor cortex is not affected in Alzheimer's disease. Patients with Alzheimer's disease don't go blind and they don't become paralysed because their primary cortex, primary sensory motor and primary visual, is not affected by the disease process. You don't find amyloid there, and you find intact metabolism in those areas. So we can use this as a reference area for reading the rest of this image. And you can see in this patient with Alzheimer's disease that relative to the sensory motor cortex, there is clearly hypometabolism in the parietal cortex and also in the prefrontal cortex. By prefrontal, we mean in front of the motor strip. The motor strip is part of the frontal lobe, but it's the very dorsal back part. So prefrontal refers to in front of the motor strip. So here we're seeing clear hypometabolism in parietal and frontal cortex relative to the preserved primary sensory motor cortex. So always start with your brain orientated the right way. Then do these things. Look at parietal versus sensory motor, and also frontal versus sensory motor. Look at the posterior cingulate gyrus. This should be the brightest thing on that slice. Now, people didn't realise that. It was only when Neurostat and these automated programs came up, they kept showing a reduction in this part of the brain in very early Alzheimer's disease, something that clinicians hadn't picked up visually because they weren't really fully aware that this actually should be the brightest thing on the slice. If it's not the brightest thing on the slice, it's hypometabolic. The visual association cortex and the primary occipital cortex should be compared particularly to the basal ganglia, the striatum part, the putamen caudate nucleus. They should have similar activity. So medial occipital cortex should be equal to striatum. If it's not, it's down. And then you've got to start thinking about things like dementia with Lewy bodies or other variants, posterior variants of Alzheimer's disease, or is this patient blind, or do they have significant visual impairment? Check the subcortical structures, so the putamen, the caudate nucleus, the thalamus, for evidence of little holes, lacuna infarcts, that can point you towards a contribution from vascular disease to the patient's presentation. Also, you tend to see some asymmetry and involvement of the anterior striatum in frontotemporal dementia. So the caudate nucleus and anterior part of the putamen often go down in frontotemporal dementias, and they may do it asymmetrically. And if they're also asymmetric, it points to another condition, corticobasal degeneration. So if you have ipsilateral hypometabolism in your frontal and parietal cortex, involving the sensory motor cortex, there's no preservation in that, and you have on the same side a reduction in the striatum and the thalamus, then you've got strong evidence for corticobasal degeneration. Don't forget the anterior and the medial temporal lobes. The anterior temporal lobes, as I'll show you, are very important for semantic dementia. The medial temporal lobes are interesting. In young people, there's not much medial temporal atrophy in Alzheimer's disease. And in fact, you often see in younger people that the lateral temporal cortex has lower metabolism than the medial, whereas in a normal person, the lateral has greater metabolism than the medial. But in older patients, there is hippocampal atrophy and associated hypometabolism. And if all you see is severe medial temporal reduction, then you may be seeing cases of this thing called primary hippocampal sclerosis, which we're now appreciating forms a significant portion of the patients of dementia in the very elderly, so 80, 85 plus. They have an amnestic problem because they're knocking out their hippocampi. It's a TDP43-based disorder. It's not Alzheimer's disease, but clinically it looks like Alzheimer's disease. They have severe hippocampal atrophy, and it can be hard to pick. In fact, diagnosis really relies on post-mortem, but it's something to keep in mind. So here's an example, just to drive home that the posterior cingulate, this is a normal brain, should be the brightest thing on the slice. So it's brighter than frontal cortex, it's brighter than parietolateral occipital cortex. Here we have a patient with Alzheimer's disease. Interestingly, there is a little bit of preservation in this sort of mid part of the cingulate gyrus, but behind that, the precuneus and part of the posterior cingulate there's a reduction. Now, the posterior cingulate I'm making a big thing about. It's important for Alzheimer's disease. It's important when thinking about other things too. So dementia with Lewy bodies. In some studies at post-mortem, it's been described that this is the second most common cause of dementia in the elderly. I'm not personally sure about that. I suspect there's some bias into people that donate their brains after death. So the strange cases may actually pop into these studies more often. But anyway, it is a condition that can be confused with Alzheimer's disease. It tends to have some characteristic features that should tip you off, such as visual hallucinations and Parkinson's symptoms and a few other things. But they may not be picked up, or they may not be there at the initial presentation of the patient. The FDG PET pattern typically looks like this. that you've got the parieto-temporal reduction that you see in Alzheimer's disease, but you've got preservation of the posterior cingulate. These people don't get much hippocampal atrophy and they have relatively preserved memory. It's more of a confusional visuospatial crashing the car, loss of judgment type presentation, rather than a memory. When you test their memory, they may complain about their memory, but when you test it, it's usually not too bad. And that's reflected in the PET, in that the posterior cingulate, being part of this memory circuit, is still functioning. So the cingulate island sign, but a reduction in the occipital cortex. So that's a bit contrary to your normal Alzheimer's disease. And involvement, particularly of the medial occipital regions, is also atypical for Alzheimer's disease. So if you get this picture, it looks like Alzheimer's, but the occipital lobe's also involved and the posterior cingulate is preserved, then you can be fairly sure you're dealing with dementia with Lewy bodies. Again, how to judge this area? Well, look at the activity here in the striatum versus the medial. They should be roughly the same. Clearly, when you look at that relative ratio, there's significant reduction here. Now, unfortunately, nothing's perfect in life, and there is a variant of Alzheimer's disease that does look like this. It's called the posterior cortical atrophy variant of Alzheimer's disease. Again, they present with visuospatial problems. They don't have the hallucinations and they don't have the Parkinson's. Their memory is relatively intact as well, but they have underlying Alzheimer's disease pathology. So when I see this, if it's a male, an elderly male, I'll go for dementia with Lewy bodies. If it's a female, I'll say could be posterior cortical atrophy variant of Alzheimer's disease. Parkinson's disease and DLB are far more common in males than in females. Alzheimer's disease is roughly 50-50, slightly more common in females. Frontal hypometabolism, here's an example. This is my list of causes. Whenever I see frontal hypometabolism, I usually put in a differential diagnosis, a list of the possible causes in my report. So the classic one is the behavioural variant, the BV or behavioural variant of frontotemporal dementia, which used to be called Pick's disease, but that's a specific pathological finding, and there are some other causes of behavioural frontotemporal dementia apart from Pick's body-related Pick's disease. The PNFA variant of frontotemporal dementia. It's a mouthful. It stands for primary non-fluent aphasia. These are people that present with a language problem. They're struggling to get their words out. They have trouble naming things. However, they can repeat sentences, and other areas of cognition aren't too bad. And that's often a tau-related form of frontotemporal dementia that predominantly affects the dorsal part of the left frontal lobe. I'll show you a bit more on that later. The frontal variant of Alzheimer's disease, because nothing's perfect in life, Alzheimer's disease, particularly in the elderly, can sometimes look like FTD. Now, FTD is largely a disease of people in their 50s and some people in their 60s. If you have an 80-year-old with frontal hypometabolism, I don't put FTD at the top of my differential diagnosis because it's a pretty rare condition at that age. So you have to change the order of things. Chronic schizophrenia, well, that should be obvious on clinical history, but that is associated with frontal lobe atrophy and frontal hypometabolism. Progressive supranuclear palsy, where people keep falling over, can't look up, their eyes don't move, that gives frontal hypometabolism. A lot of small vessel disease often has a frontal predominance, and that can cause some deafferentation and give you some frontal hypometabolism, particularly in the elderly. And then there's other reported causes: obstructive sleep apnea, excessive alcohol, even severe depression have been reported to cause some frontal lobe changes, although it's a bit questionable. Frontal lobe metabolism does decline with aging. If you're comparing to a normal database, you've got to take the age of the person you're putting into consideration. So mild frontal hypometabolism on the display when you've compared to 72-year-olds for a 50-year-old is very significant. If it's an 80-year-old that you're comparing to a database made up of 70-year-olds, it doesn't mean anything. So keep that in mind. Quantification with PET, well, Neurostat came along. There's a number of programs now, and this is fabulous. It improves the accuracy. This is a study we did of 68 amyloid scan positive ADs versus 32 amyloid scan negative. Looked at the sensitivity and specificity of FDG PET in these people. There's an expert, who's me. Didn't make all that much change to an expert, but the novices became as good as me. They could put me out of a job by using this program. It's so easy to read, it's so fast, and it increases your confidence and the confidence of your referring doctor. So I don't think anybody should be reading FDG PET without using one of these programs. This is the literature just showing the superiority of Neurostat from each one of these points is a study that's been reported in the literature, and look at the performance of Neurostat there versus visual. This is looking at likelihood ratios for distinguishing AD from healthy controls. And you can get these wonderful patterns. We have this plastered around our reporting room. I give it to all our trainees at the beginning of their training, because this is all you need to read FDG PET. So if you've got cameras, take photos of this. You can see the Alzheimer's pattern: parietal, temporal, posterior cingulate, precuneus. The logopenic aphasia variant, it's Alzheimer's disease but presenting with a speech problem. Looks like AD, except it's worse in the left hemisphere. Dementia with Lewy bodies, you've got parietal, but you've got occipital, lateral and medial involvement as well. Behavioural subtype of frontotemporal dementia, frontal lobes, and if you know where you're looking, you'll realise that this is anterior cingulate and this is the anterior striatum. That also can go down in frontotemporal dementia. Progressive non-fluent aphasia subtype of frontotemporal dementia, as I mentioned, dorsal part of the left frontal lobe, both lateral and medial. Semantic dementia, another speech problem, presents with anterior temporal lobe hypometabolism on the left. So they're the main patterns you need to remember. Once you've got all those in your head, you're pretty right for reporting FDG PET. Simple rules, though. Unfortunately, in real life, particularly in the very elderly, you get a bit of this and a bit of that, some frontal reduction, some parietal reduction. Which way are you going to go with your report? Well, I do use the patient's age to sway me, but there's also this paper that came out from the University of Utah looking at Neurostat, and basically they put the scan in a scale, and if it tipped backwards based on where all the Neurostat abnormality was, then it was AD, and if it tipped forward, it was frontotemporal dementia. So you can weigh it up in your mind. I'm looking at my Neurostat or other quantitative display. Is more of the activity posterior or is more of it anterior? And that's the way you go with your diagnosis. And they claimed 98% specificity in autopsy-confirmed cases. Sounds too good to be true to me, but it's a handy little rule to use when you've got those questionable cases. Skip that, running out of time. This is basically to show that FDG PET does mirror tau deposition in patients with Alzheimer's disease, whereas amyloid PET doesn't. How good is FDG PET? This is an oldie but a goodie, a study from Berkeley in 2007, which they looked at the sensitivity and specificity of clinical diagnosis versus blinded PET diagnosis when patients first presented, and then they followed these patients to post-mortem. And you can see that at first presentation to a memory specialist clinic, FDG PET outperformed clinical assessment, both sensitivity and specificity. So if your clinician is arguing with you, stick to your guns, because the FDG PET is more likely to be correct than the clinician. We'll skip that. Brain SPECT, more widely available, cheaper, unfortunately not as good. It's about 15% less accurate than PET. The problem is it's harder to read. The confidence of everybody involved, the reading people and the clinicians, is lower. And here's an example of why. This is the same patient. They had a SPECT and a PET. They do have established dementia. Their mini mental state's 22, so there's no doubt they've got dementia. The FDG PET is extremely clear, either just looking at it on SLICE or on Neurostat. The SPECT is showing the same thing. If you're confident, there's a reduction here, and in the posterior cingulate. the neurostat showing a sort of blotchy reduction in the right sort of area. So, but this is actually a patient who's clearly already demented. So in milder cases and sort of mixed, more questionable cases, SPECT really tends to let you down. But there are some limitations of PET. This is my last slide. The hypometabolism of PET does reflect the severity of clinical deficits. So the findings might be subtle in mild cognitive impairment. You might just see a little bit of something in the posterior cingulate precuneus and a wisp of some reduction in the parietal cortex. Mixed clinical features are often associated with mixed FDG findings. So if you get a referral saying this person's got frontal problems and memory problems, which one is it? Unfortunately, there's a chance your FDG PET will show frontal lobe and Alzheimer's type changes, and then you've got to try and make a call. Changes are less clear in the very elderly. If you have a 60-year-old coming in with genuine cognitive impairment, your FDG PET is going to be very clear and very easy to read. Unfortunately, if you get an 80-year-old coming in with clear cognitive impairment, not so the case. You often may find that the findings are somewhat subtle and mixed. There is still a limitation. The specificity for type of dementia still seems to be stuck down at around the 70 to 80% mark. As I've mentioned, some sites only give a visual read. I strongly discourage this. It makes you at least 15% less accurate than an expert if you just do that. So I hope that's taught you how to read an FDG PET. Thank you. Okay, so for the rest of the session, we're going to present cases. We're going to do a few each, and this will be a show of hands. We're not sophisticated enough here to have set up the app. So, first case, a 50-year-old woman with breast cancer treated with surgery and chemotherapy, continuing on tamoxifen, started noting memory lapses, important family history that her mother had Alzheimer's disease diagnosed at the age of 64. She came to medical attention and in 2009 saw a neuropsychologist who said that her memory was entirely unimpaired, but there were some deficits in executive function, high-level attention and concentration. Conclusion, findings combined with a static impairment since chemotherapy is not consistent with Alzheimer's disease. And the report went back to the specialist, and the specialist wrote the letter to the primary care physician saying chemo brain has been discussed. We reassured her their assessments were not consistent with Alzheimer's disease. She did have an MRI. Now, I want you to have a close look at this MRI and then tell me which of the following statements is true. Hippocampal atrophy is a reliable feature of early onset Alzheimer's disease. The MRI scan shows hippocampal atrophy. Medial parietal atrophy is only seen in late onset Alzheimer's disease, and is this MRI scan within normal limits? So this is testing your MR knowledge as well. So firstly, hippocampal atrophy is a reliable feature of early onset Alzheimer's disease. True or false? Those that think it's true, please raise your hands. Those who think it's false, raise your hands. Correct. Hippocampal atrophy is often not seen in early onset Alzheimer's disease, and that's defined as before the age of 65. The MRI scan shows hippocampal atrophy. So for those of you who aren't too sure where the hippocampi are, I'll just show you. So these are the hippocampi in here in the medial temporal lobes. They should occupy virtually all of this space. What you're looking to see if there's too much CSF developed around them. And the answer is, do you think this shows hippocampal atrophy? Yes? No? Good. Quite normal, these hippocampi. Medial parietal atrophy occurs in Alzheimer's disease. Is it restricted to late onset Alzheimer's disease? Yes? No? Correct. You're a very educated bunch, or you can predict what I'm going to say. Medial parietal atrophy can be seen if you know where to look, but it's not easy. It's a bit tricky. Most radiologists don't go looking for this, but it has been described in earlier onset Alzheimer's disease. The MRI scan in this patient is within normal limits. Yes? Correct. An FDG PET was done. I'll show you the PET, then I'll show you the neurostat, and then we'll ask some questions. So have a look at the PET. Here's the neurostat. What does the PET show? Who thinks it shows dementia with Lewy bodies? Who thinks it shows Alzheimer's disease? Who thinks it shows frontotemporal lobe degeneration, or FTD? Who thinks it shows chemo brain? Okay, despite the fact this person is in their early 50s, it's a typical FDG PET of Alzheimer's disease. As I mentioned in my talk, in young people with Alzheimer's disease, the findings are quite distinct, as they are in this case. Chemo brain is a nebulous concept. People having various forms of chemo do get some executive dysfunction and other sort of somewhat vague cognitive problems, but they don't get PET scans that look like that. The patient came back for 12-month review, and neuropsychology said stable findings. The specialist thought the FDG PET findings were inconsistent with neuropsychology. In the meantime, the patient had become more anxious and had stopped teaching. The specialist said in his letter, at this stage, we cannot make a diagnosis of dementia, and in particular, there is no evidence of Alzheimer's disease or any other neurodegenerative disorder. This specialist did not want to face the harsh reality that he had a 50-year-old woman with a young child who had Alzheimer's disease. The patient came back for further review and was showing significant and fairly rapid cognitive decline. Scoring 1 out of 12 on a memory task, the specialist still didn't want to make a diagnosis, did the FDG PET again a year later. Here is a comparison. Just have a bit of a look. There might be some questions following this. Which statement is true? The severity of hypometabolism correlates with the degree of cognitive impairment. Who thinks that's true? Yes? Good, it does. Amyloid PET is better than FDG PET for monitoring disease progression. Who thinks that's true? Who thinks that's false? Correct. Amyloid accumulates so early and accumulates for 30 years. By the time you get to the symptomatic phase, you've already got a brain full of amyloid and you don't see that much change. So while they can be declining rapidly, you're not seeing much of a change in amyloid. And in fact, in advanced Alzheimer's disease, the amyloid signal tends to decline on a PET scan. So yes, FDG PET does correlate with cognition and severity, amyloid doesn't. Repeating FDG PET in equivocal cases should be done at 3 or 6 months intervals. Who thinks that's true? Who thinks that's false? Okay. The reality is the FDG PET does decline fairly slowly. If we go back, it's a little bit worse a year later in this woman who is progressing cognitively, and she's young, so you do expect clear findings. It really does take a year, 18 months, maybe even 2 years before you can make confident, you can confidently see progression on FDG PET visually. The clinician was still uncertain, so an amyloid PET scan was performed. So here's the patient's scan. This is PIB versus the healthy control. Patient was then informed finally that the scan was positive and she had Alzheimer's disease. Her mini-mental state by this time was 22. So some years after presenting to this specialist, she was commenced on Aricept. Genetic testing was done for the autosomal dominant early onset Alzheimer's genes, but it was actually negative. Compared to post-mortem diagnosis, FDG PET is more accurate than expert clinical opinion at initial evaluation for detection of Alzheimer's disease. True? Okay, correct, as I showed earlier. The post-mortem studies do support this, and this is that post-mortem study. This use of amyloid PET did meet the appropriate use criteria, but this can be applied to FDG PET too. Early onset dementia, MCI, and dementia of uncertain cause after expert assessment are the appropriate uses of PET imaging. I'll give one more case and then hand over to my colleagues. 61-year-old male with 4 years of worsening ability to name objects, more recent decline in comprehension and arithmetic, lacking emotion, rigid thinking, Disinhibited, still working. Must be a politician. Mini mental state score is 26. Memory is good. Unable to name animals. Suspected diagnosis was frontotemporal dementia of the semantic subtype with Alzheimer's disease, a less likely possibility. MRI was ordered. Here's the MRI with some questions. So I'll give you a minute to have a look at the MR. Who thinks this MRI is normal? Who thinks it shows hippocampal atrophy? Who thinks it shows anterior temporal lobe atrophy? Who thinks it shows frontal lobe atrophy? And who thinks it shows evidence of a left-sided stroke? The answer, the most significant abnormality is the anterior temporal lobe atrophy. So here you can see there's a lot of CSF in these sulci because of grey matter loss. Worse on the left than on the right, it is bilateral. There is some reduction in the head of the hippocampi, in the anterior hippocampi, so there is some hippocampal atrophy as well. As I mentioned, hippocampal atrophy is not all that specific for Alzheimer's disease. You get it in most of the frontotemporal dementias to some degree, particularly in these anterior temporal lobe variants. So, sorry, I should have been showing you this one. This is where it's really clear that there's anterior temporal lobe atrophy, worse on the left. Frontal lobe could be a little atrophic as well, a bit hard to tell. And is there any evidence of a stroke? Not really. Okay. So he was seen by a specialist who felt that frontotemporal dementia of the semantic dementia variety was likely. This specialist ordered an FDG PET and got a PIB scan done by putting the patient into a research study. So here's the FDG PET. Take a minute to look at it. I'll show you the neurostat, then ask some questions. Here's the neurostat. And what is this FDG PET most consistent with? Previous left temporal lobe traumatic injury? Who thinks yes? It actually could be, but given the history and the presentation and the findings on MRI, that's very unlikely in this case. A left middle fossa arachnoid cyst. This is a benign finding on MRI scans or CT scans. It's a unilateral finding where it displaces the anterior temporal lobe, but you can see it quite clearly on the MRI. Is this consistent with semantic dementia? Yes. Correct. Is this Alzheimer's disease? No. It's involving the temporal lobes, but it's the anterior temporal lobes. Alzheimer's disease involves the lateral temporal lobes going up into the parietal cortex. So there's a bit of lateral involved here, but really the most profound abnormality is in the anterior temporal lobes. So this is really pointing you towards semantic dementia. Could this be corticobasal degeneration? No, that shows frontoparietal reduction, usually asymmetrical associated reduction in striatum as well. Simple rules of classification I mentioned. Could this be FTD? Could this be AD? So if you put this in a scale on the neurostat, is it going to tip forward or backwards? Well, it's going to tip forward towards the front, the anterior part of those temporal lobes. So it fits that general rule of distinguishing FTD from AD. This person actually did have a PIB PET scan. Have a look at that. And that was it for this case, sorry. And the PIB PET scan, I better give you the answer, seeing I didn't ask a question, is completely negative. This is just showing the non-specific white matter uptake in the cortex and cerebellum, but no cortical uptake anywhere. So I will now hand over to my colleague, Professor Kirk Fry. So if the projectionist could please change over to Kirk Fry's cases. Thank you.
Well, Chris, we could continue with your cases, but I'd get them all wrong. So I have 3 cases to show. They're all related one to another, but you'll see what links them as we move through this. So the first case is that of a 65-year-old man who had progressive difficulty, particularly with impairment of his short-term memory. But in the clinic, on discussing with his immediate family, he also had developed disrupted sleep. And then more recently, he's actually experienced some visual illusions where he sees kids playing in his yard, but no one else seems to appreciate their presence. His referring doctors had put him on donepezil and fluoxetine already. And here's his scan, which I guess on your screen is easier to see than on mine. So this is his FDG PET. I'm going to show you grayscale images, but then following Dr. Rowe's suggestions to us all, we routinely process these against a normal database using a commercial software package. And these voxels that are now colored in and overlaid demonstrate those that are significantly reduced compared to an age-similar group of normal individuals. So take a look at the distribution of the abnormalities here. And the question to address here is, what's your most likely diagnosis based on these data? Is it sleep-disordered breathing, typical sporadic Alzheimer's disease, Lewy body dementia, or behavioral variant frontotemporal lobar degeneration? So how many of you would vote for A? I see no takers. How about B? Uh-oh. C? I see hands going up. And D. So I think you're right. The consensus answer here was C, and the reason for this is we won't go back, but was because of the involvement of visual cortices. And the official interpretation of this was first that we saw asymmetrical hypometabolism throughout the association cortices of the temporal parietal regions. Posterior cingulate precuneus was also hypometabolic. When one sees asymmetry, which is very common in all of these neurodegenerations, the way you know it's neurodegenerative as opposed to subcortical ischemia or some other more random process is that the asymmetries, which side is worse involved than the other, is shared amongst all of these sites that are abnormal. This clearly connotes one of the neurodegenerations. So that pattern is typical of Alzheimer's disease. However, you all noted there was additional hypometabolism in the primary visual cortex. And this is indeed most consistent with Lewy body dementia. However, the referring physician was reluctant to accept this diagnosis. Why, I'm not sure. So the question then is there a confirmatory imaging study we can do to convince them this is the case? So would you do MRI with morphometry? Would you do an ioflupane SPECT scan? Would you do an A-beta amyloid scan? Or would you do tau PET? So how many would do A? No takers. How about B? We have a lot of takers. And C? Amyloid PET? There was one hand that went up or so. And what about D? Okay. So amongst these, the MRI, although the MR enthusiasts will tell us that MR is useful in looking for degenerative dementias, is not a clear distinction that I find reliable. Similarly, an amyloid scan in this case is not going to distinguish between the major competing diagnoses of Alzheimer's versus Lewy body dementia. Both can be amyloid positive. Tau PET is really a research tool at the present time. So ioflupane is right. And here's an exemplar, although not with ioflupane. This was done in our laboratories years ago using VMAT2 imaging with tetrabenazine. And here we sought to contrast the occipital cortex hypometabolism, in this case hypoperfusion, in separating dementia with Lewy bodies from Alzheimer's disease. And you can see that that's the open symbols here. So that's this curve. And you can see it does far better than chance, but about 30% or so of DLB patients don't manifest significant occipital hypometabolism. Whereas the loss of nigrostriatal presynaptic dopamine terminals is a virtually perfect diagnostic distinction here. And so it turns out that ioflupane SPECT here from the group at Newcastle has a very similar ability to separate dementia with Lewy bodies from other dementias. And here is the ioflupane SPECT scan in this individual. Now, I know we haven't talked about how to read these. I guess that comes tomorrow, but I imagine many of you are aware of this anyways. So what's your impression now? This is normal nigrostriatal projections, medication effect due to donepezil and fluoxetine, severe nigrostriatal degeneration, or cerebrovascular disease. So who votes for A? No takers. How about B? I have to think a little, but no. How about C? I agree with you. And D, cerebrovascular disease. Well, it's not. So indeed, this is severely bilateral reduced DAT expression. And together with the FDG picture, this virtually confirms a probable diagnosis of dementia with Lewy bodies. And it has management salient contribution here. So it's reasonable to continue the medications already started, but if one wants to treat these visual illusions or hallucinations, despite that they're non-threatening, you would definitely not want to offer a potent anti-D2 antipsychotic. That precipitates very severe medical side effect consequences and even may lead to death. So if you had to suppress these illusions, quetiapine or pimavanserin might be better tolerated and the agents to select. Okay, another case. This is a slightly younger, a 60-year-old woman who has a couple of years progressive difficulty with visual recognition of objects. So she sees things, but she has trouble naming them and certainly can't deduce what they might be good for or what they're useful for. She also has intermittent word-finding problems and more recently has developed impaired short-term memory. On examination, she's really more severely affected than the history would lead to believe. She has acalculia, she can't repeat sentences accurately, and she's unable to perform any delayed recall on the MOCA examination. And she'd been placed on fluoxetine for a depressed mood. So here is her scan. Take a look at this for a moment. I think you can derive a sense as to what's abnormal here, but the reliable addition of the colored in voxels, I think, sustains your impressions. So take a look at this pattern. And so the question here is, what's the most likely diagnosis amongst the following four? So she has cerebrovascular disease. She has typical sporadic Alzheimer's disease. She has Lewy body dementia, or she has a focal Alzheimer's disease variant. So how many vote for A? No takers. B? Okay, one. C? We got a vote in favor, and then D? The majority. Very good. So this, again, similar to the prior case, shows hypometabolism in those association cortices posteriorly, as well as engagement of the posterior cingulate precuneus bilaterally. Again, the findings are asymmetrical but consistent amongst all of those sites. So that aspect of it is typical of Alzheimer's disease. However, those of you who didn't vote for typical AD noted that there's additional hypometabolism, in this case involving the lateral occipital and parieto-occipital association cortices, but sparing the cuneus. So the primary visual cortex was uninvolved. And this is most consistent with the metabolic description of PCA, or posterior cortical atrophy. And if we thought that's what she sustained, then the next question is, what imaging procedure would be best to further characterize her case? And that is MRI with morphometry, ioflupane SPECT, an A-beta amyloid scan, or a tau PET scan. So how many of us want MRI to further classify this? We have an MR vote. How about ioflupane SPECT? No takers. A-beta amyloid? Okay. And tau? And I've already told you that's for research purposes. So I agree with those of you who voted for amyloid, the reason I'll explain in just a moment. But here is the result of her clinical amyloid study and the question associated with this. Take a look at the 3 slices I've provided for you. What's your interpretation of that scan? Is this a normal amyloid scan? Does it show Alzheimer's disease? Does it show Lewy body dementia? Or does it show a high density of fibrillary amyloidosis? So how many of us want A? Good, you've all learned. B? Okay, C? And how about D? That's exactly correct. So remember, the presence of an abnormal amyloid scan does not give a diagnostic classification in terms of Alzheimer's disease versus related degenerations. And remember, 60 to 70% of dementia with Lewy body cases are amyloid positive. So it certainly doesn't distinguish between B and C, nor does it diagnose Alzheimer's disease. In that many cognitively normal, very elderly individuals will have an amyloid scan that looks like this. But this does show a moderate to high density of fibrillary amyloidosis. And why do we care? Well, this scan, and you would have noted a loss of gray-white contrast throughout all of those cortical areas I displayed. And in the coronal image, the cerebellar cortex was much less intense than the entire cerebral mantle. So this is indeed clinically and FDG, a posterior cortical atrophy case, but PCA as a clinical syndrome is most often a focal variant of Alzheimer's disease, but can be seen in dementia with Lewy bodies, although she had no clinical features of DLB, can also be seen in some instances in corticobasal degeneration, and even in spongiform encephalopathy. So the value here of the amyloid scan is to convince the referring physician and managing physicians that this is a focal variant of Alzheimer's disease, and the existing symptomatic therapies for AD are indicated. Okay, third and final case. This will be a little brief. We have a mid or early 60s-year-old female. She has a 1-year history of memory complaints. She forgets appointments. She loses objects around her home. She forgets why she went to the kitchen and what she was trying to pick up from the refrigerator. Her past medical history is remarkable for anxiety, depression, and more recently for fibromyalgia. And she's being treated with gabapentin for that pain syndrome. So the question is, what's the nature of the cognitive impairment here? And here is the FDG PET scan. So take a look at that for a moment. And here are the magic colored voxels, so you can see where she is hypometabolic, despite that perhaps you didn't appreciate that without the overlay, but there you are. And so the question now, what's your most likely diagnosis here? So A, typical sporadic Alzheimer's disease. B, pseudodementia. C, Lewy body dementia. Or D, behavioral variant frontotemporal lobar degeneration. So how many of us like A? Okay, how about B? Couple of hands. C? Okay, we get some votes there. And D? Nope, no takers. Well, a summary of this is that there's abnormal cortical glucose metabolism confined to the cuneus, confined to the primary visual cortex, with no association cortical hypometabolism with intact posterior cingulate precuneus metabolism. So it's an otherwise normal FDG scan. So this pattern is not what one sees in any of the neurodegenerations we know of, and it prompts an important quality assessment or quality assurance aspect of the exam, and that is one needs to go to the technologist and ask, what the heck did we do? And the answer was that this patient was in a unarousably disconsolate mood at the time of the study and refused to keep her eyes open during the isotope incorporation phase of the examination. So she was essentially studied with her eyes closed. And so given this, our diagnosis is that of pseudodementia. She really has normal metabolic activity for one with no visual input. So she doesn't have a neurodegenerative problem, and she really needs more focused management of her mood disorder. Now, what I'd leave you with is this, and this is my personal opinion, but I think it's sustained by studies you've seen and studies you will see. I really favor, in the setting of a differential diagnosis of cognitive decline or mild early dementia, where the management may be having an impact, that we start with the FDG PET scan. We have the most experience with this. It's disseminated widely. We can all do it, and I agree with Dr. Rowe that these packages to assist with statistical thresholding for your analysis are quite valuable. In the context of what to do with the FDG scan results, of course in conjunction also with clinical history, that DLB pattern of occipital primary visual hypometabolism, I think, is quite predictive, as is the cingulate islet sign. If the FDG scan shows that characteristic pattern, the patient has DLB. The case I showed you where we did a DAT scan, I think the DAT scan was unnecessary, but confirmed. And similarly, if the FDG pattern is normal, there's not a neurodegenerative dementia present, and one should manage the behavioral characteristics aggressively. Now, if you have a patient that has a typical AD pattern, remember that some of those could have dementia with Lewy bodies and simply not manifest the FDG characteristics that distinguish some, but not all of them. So in that case, if it matters to management, we would advise considering a dopamine terminal scan, a DAT scan, or an Australian AV133. If that scan is normal, then you have Alzheimer's disease. But if it's abnormal, it's DLB with the attendant concern about how not to manage that with antipsychotics if visual problems are the problem. If alternatively there's a focal pattern or an unusual pattern in the FDG that looks like a frontotemporal lobar degeneration or some other off-target pattern, in this case, doing an amyloid scan will help us to resolve whether that's an atypical presentation of Alzheimer's disease versus a frontotemporal lobar dementia or another dementia that lacks amyloid deposition. So this is my recommendation about how we should use the tools we have at hand, but again, personal opinion and not established with evidence basis as yet. And I'll end there. Thank you.
Thank you. I'm just going to make a few comments. I did forget to mention in my talk on how to do an FDG PET that you do have to have the visual environment constant and reproducible every time you're studying a patient. So at our centre we have people eyes opened in a semi-darkened room. Do you darken the room?
It's dimly lit so that it's not obtrusive. But you can see, that's the critical thing.
And then referring to Kirk's diagram at the end there, I agree, it's very sensible, but a cautionary note that in the very elderly patient, everything starts to fall apart. So that's a great diagram for people under the age of 75. Over the age of 75, a bit of caution is needed in your conclusions that a normal FDG PET means there's no neurodegeneration, etc.
Yeah.
Now, turning over to our final case presenter, Professor Pedro Rosaneto from Montreal.
So it's not going to be the same style. It's going to be a little bit different. So this is a case of a 55-year-old patient who came to the consultation with his wife, who provided most of the information about the clinical history. And she described that her husband was a priest with a very persuasive and eloquent oratory. He was highly appreciated by this religious community. However, during the last 3 years, there was a clear impoverishment of the ability to this individual to preach. And during the services, he started to lose the thread of his narratives and get confusing on quoting the Bible. He was very embarrassed because of that. His ability of multitasking in the activities of the church began to deteriorate, and a year later, he clearly acquired difficulties to retain information regarding conversations, as well as the ability to organize his time and accomplish all the items of his agenda. Apart from the social isolation, from the neuropsychiatric perspective, there was no history of disinhibition, reduced of impulse control, substance-related disorders, stereotypical, ritualistic symptoms, hallucinations, or delusions. He was previously evaluated by a neurologist who made diagnosis of Alzheimer's disease based on the clinical history, an MRI that didn't show much, and a PET FDG. And he came up to us with 10 milligrams of donepezil every morning. This patient and his family, he lived in many, many places with very precarious urban infrastructure, including the sub-Saharan Africa. And he was exposed to many tropical diseases, so they were, in the business of their church. And his previous medical history was negative for cardiovascular diseases, high blood pressure, hyperlipidemia, stroke or diabetes. There was no history of current sleep disorders, cardiovascular, respiratory, urinary, sensory, or motor complaints. His family history was very interesting, was negative for Alzheimer's disease, but his father has ALS, and he accepted to take part of our research protocol. So the physical examination was remarkable. During the mental status examination, he was cooperative, attentive, responsive, and partially oriented in time and space. He was not able to correctly tell the months of the year in the reverse order. He made a few mistakes on the serial sevens. The design and copy of the clock was clearly abnormal. Regarding reading and repetition were normal. The writing skills were impaired, and the content of the language was impoverished. Verbal and semantic fluency was reduced, and the single word and sentence comprehension were normal. The anterograde memory showed deficits that were not corrected by cueing, so the MoCA was 12 out of 30, and the Mini-Mental was 17 out of 30. Very simple questions. Do you think there is an individual that an amyloid imaging should be conducted? Do you think he meets the criteria, the appropriate user criteria to use? Who thinks that he is a candidate for amyloid? Please raise their hand. Only one? Two? Three? Okay, so this is the imaging of this individual. So this is an MRI showing a kind of diffuse atrophy. When you scan him again, he had the atrophy of the hippocampus. This is a flared sequence showing that there is very little or no effect of cerebrovascular disease. This is the PET FDG showing the classical pattern of Alzheimer's disease with a very important reduction of the metabolism in the parietal cortex. So this is the amyloid imaging showing that pattern of amyloid deposition. So we did this with the AZD 4694 or NAV 4694 is the same ligand, so it's different name. And this is the tau imaging of this individual showing a significant deposits of tau in areas that are frequently affected by in patients with Alzheimer's disease. So the take-home message here is that the biomarker here supported diagnosis of Alzheimer's disease. And the big challenge of this individual is that he was very young and his father had ALS. I think the justification of amyloid here perhaps would somehow corroborate with the diagnosis of Alzheimer's disease. And amyloid imaging support the use of cholinesterase inhibitor in this individual. And biomarkers have a modest, but I think a significant impact on the management of this individual with early onset dementia. The second case is a case of an 80-year-old man, a retired teacher. He came to the consultation describing word-finding difficulties. He was later on he was become a little bit more dependent on his agenda, calendar, notes as compared to some years ago. He had a hypertension and diabetes that was somehow well controlled. His wife also noticed some degree of a social withdrawal possibly due to these language difficulties. So a family history was negative for dementia, and he decided to volunteer to our research program. His clinical dementia rating was 1. The MoCA was 19 out of 30. The Mini-Ment was 24 out of 30. He made on the examination mistakes on Serial 7. Anterior great memory evoked by delayed recall showed deficits which were even partially corrected by cueing. Speech was mildly affected. The repetition was normal. The judgment and abstract thoughts were appropriated. He had a normal Boston naming test. He scored 6 out of 25. And the semantic fluency was reduced. However, the phonemic letter fluency was normal in this individual. So it has some features of semantic dementia. And he was on the Nepezil on 10 milligrams daily. Do you think this is a case that amyloid imaging would be recommended, yes or no? Professors?
Sure.
Well,
8 years
my
old.
colleague on my left would say an FDG PET should be done first. You might have a point.
All right. I couldn't get the FDG to bring because it was done in the health, under his clinical care. I couldn't get it. But there was the diagnosis of the FDG was Alzheimer's disease. So here is his, oh, sorry. Here is his amyloid scan, and the amyloid scan was negative, right? And this is the tau scan, and the tau scan shows a very significant deposition of tau in the entire brain. So we don't have a histopathology of this patient. We don't know exactly how to use our tau imaging agent, if our tau imaging agent is sensitive to other aggregates, including TDP43. We don't know yet, we didn't try. And possibly this can be a kind of a FTD-like disease. But we believe that this is the absence of signal on the amyloid PET and the positive tau PET support in vivo diagnosis of, so up to this moment, a pathological condition called neurofibrillary tangle predominant dementia. So this is clinical pathological entity is characterized by abundant allocortical and isocortical fibrillary pathology, usually extending up to BRCA 3 or 4, in the absence of mature plaques. Because again, with amyloid, we can only see a specific type of mature plaques. And these individuals with neurofibrillary tangle predominant dementia, 25 up to 25% of them, they have some deposits of amyloid, but this amyloid is invisible to amyloid imaging. After these scans, we decided to stop with cholinesterase inhibitors to this individual. So as a take-home message, a small fraction of the population with dementia, so biomarker profile characterized by positive tau and negative amyloid scan. This clinical pathological entity supports the clinical diagnosis or the clinical pathological concept of a neurofibrillary tangle predominant dementia. And further studies focusing on the natural history, genetics, and therapeutic management should be conducted in order to know what to do with these individuals. And looks like that 4 to up to 10% of these individuals, of patients with more than 8 years old, and they can present this type of cause of dementia. And in fact, the 90+ is the fastest growing segment of our population in some countries. And I think it's an interesting application of the tau imaging in the differential diagnosis of individuals. I'm not saying that this has a direct clinical application, but it's a case that made me think a lot about the possible clinical applications of tau imaging. And tau imaging must be clinical relevant for differentiating this type of pathology, neurofibrillary tangle-predominant dementia, perhaps from other frontotemporal dementia cases. And one of the questions that I was thinking when they had the opportunity to evaluate this patient is the fact that perhaps what you see as a primary aging-related tauopathy, perhaps a fraction of these patients will progress to this entity. And we are thinking perhaps that there is another cause of dementia, which is not necessarily an Alzheimer's disease, the way you're conceptualizing today. And I think it's an interesting case to share with you and to hear what you think about that. Thank you so much.